I mean, it just gets back to kind of a lot of stuff that's starting to percolate more and more about focusing back on the patient-centered care. So it may start at a high level, like what are your goals for your care? You have 10 cardiovascular conditions and 20 medications, and they're all interacting, and 5 physicians are taking care of you, and you feel terrible. Maybe that's not what they want. Maybe they want something different. So in terms of technology, there may be ways then physicians can first what's important for the patient and the healthcare system to manage that patient in the best way for what the patient would like. And then back off and say, like, okay, well, you know, it sounds like you want to be independent, but I'm a little worried. Maybe you can get this tool in which will allow your son or daughter who don't live with you to know that you're doing okay. So I think physicians have a role in perhaps helping steer patients to things that may align with the type of people they are and their wishes. But in terms of just saying, like, hey, there's this technology, go use it, I think physicians have a good insight into knowing their patients much better than that, and they'd be able to perhaps figure out that, you know, prescribing that highly complicated thing to the person with really terrible arthritis, not going to happen. So I think ultimately payers do pay for things that add clinical value. They always have. I think the difference is, what do you need to show clinical value? And in the medical sphere, you know, a lot of digital health companies have tried to perhaps go around an issue by going straight to the consumer. The challenge is consumers oftentimes don't want to pay for certain things related to health just because of the historic nature of our healthcare system. Secondarily, once you get a product onto the medical side of things, then it is potentially a reimbursable product. So they'll want to see very good data that if I spend X amount of dollars today for this product that helps Mrs. Jones to do Y, that translates into avoidance of some cost or some bad clinical outcome later. So nothing new, it's just that we now have to use the same language to digital tech and mobile technologies that we've always used to implantable medical devices, to drugs, to other things. It's just that the technology moves so fast with software and some of the electronics advancements that I think we perhaps may have lost sight that good clinical science is still relevant. Now, it doesn't mean that you have to do the same level of trials and prove mortality benefits and follow patients for 20 years. Technology will be obsolete by then. And there's, I think, novel ways of using data to do meta-trials or understanding across larger data sets in which you can get some directional data. So I think payers will both expect data, but hopefully will also understand that there may be newer ways to get data in a more timely fashion to allow the technology, which probably do have value, to bubble up. The good thing with most technologies, like 2.0 is probably not that much better than 1.0, maybe 6.0. And so I think it's ultimately getting down to, why did you prescribe the first thing? And if the first thing is still meeting its needs, is it necessary to move on to the next one? Now, there will be clearly some people who want the incremental feature or benefit, but by and large, even in the medical device world, a lot of the incremental features, let's say in ICDs, are incremental. They're not necessarily change the basic function of it, monitor your heart, and defibrillate you when you're going to a lethal arrhythmia. That's the same. Now, things might change, and the difference is you don't then take out an old device of a patient if they're a new version of an ICD. So we shouldn't apply any different metrics. Just because it's external and doesn't hurt, it's still a cost. So we really have to value, like, is the data or the application or the usability something that really fundamentally affects the natural history of disease? Then sure. Then maybe it's not really 2.0, it's 1.0 something new. It was kind of interesting yesterday's announcement with AHA and Google Life Sciences, or was it this morning? I don't know when, but that's kind of stuff that there's a lot of development. There's basically big R. So big R means not just in basic science and advancements there, but even on the digital side. What are new technologies and new applications and new abilities, capabilities that exist? How those get applied, I don't know. And I think that what we have to always be cognizant of is, just because we can, should we? We can do a lot of things today, but for a lot of people, I don't want to know. Because again, I think it goes back to all of those science, all of those advancements and all of those engineering developments and computer science developments just continue to add to the armamentarium of ways of solving problems. Ultimately, it'll keep coming back to solving problems that are meaningful to patients. And the good thing is, the human body really hasn't evolved much in the last 10 years. It's probably the same, even though technology advances significantly. So I think we have to just always keep that in the back of our mind. People pretty much want somewhat of the same things, want to live a good quality life for as reasonable period as possible. technologies just potentially can help that if it's meaningfully applied. And over time, there might be a tricorder if that's a better method of diagnosing someone without an invasive procedure. Sure, and if that's a value of that. But now screening everybody for that, you might find a lot of stuff that are just false positives because the patient population is too low, too low risk. So we just have to always keep that in mind.